Greetings.
Hello.
Hello, can you hear me?
Yeah, I can hear you.
Hey, good, good. How you doing? How you doing? Can you hear me okay? I can't hear you. You're muted.
Yeah, I am Dr. Guzmão from Brazil.
Oh, nice to meet you.
Nice to meet you too.
Okay, you're not presenting, right? Are you hosting tonight?
Yeah,
Oh. There it is.
Hello.
Leandro, how you doing? Dr. Bennett?
Hi, John. How are you doing?
Good, how are you?
Good.
You-
Professor Guzmão,
Hi,
good evening.
good evening.
Good to see you again.
It's a pleasure to see you.
Yeah, it's a pleasure. So, Bennett, I think I'm going to be presenting the first lecture tonight, okay?
Okay. Is there anybody out? Is Louis coming?
I guess so. I'm not sure. Do you want,
Or who, is there gonna be someone that's gonna, I can introduce you, no problem.
okay, no problem.
Do you have anyone that wants to introduce you from your team? So there's no one that you specifically have to introduce you.
I think, I don't know if it's Dr. Borba is going to introduce me, or is going to be one of the residents, or
Okay.
Professor Kadri. I don't know.
Okay, we'll
I'll
see who
just
comes. We'll see who comes.
yeah. Okay, no problem. I'm gonna text them, see if if
Yeah.
one of them is gonna join.
Yeah, you know, if no one's there, I'll do it, no problem.
Okay, no problem. Yeah, we still have time.
Yeah.
I'm supposed to.
So all the things in Brazil.
Good. Yeah, approaching
Stable.
summer.
Yeah, that's right. It's opposite us, right?
Yeah, exactly.
Dr. Guzmão, are you in Brazil also?
Yeah, I am in Brazil.
Not the same city as Leandro, though, right?
No.
No, I mean, I live in Salvador, Bahia. It's in the northeast part of the country.
Way up, way up there.
Yeah, way up there.
Yeah.
And the city called Salvador, it's by the coast. And we have a beautiful coast as well, beaches, and it's a historic city.
Well,
Beautiful.
Yeah.
the trauma centers must be pretty big, those cities, right? Because it covers a lot of territory, right? Like El Salvador. No, really?
No, not here.
Yeah.
We have a little bit more of storms deep in the south of the country, but not in that particular part here where I live.
Where are the nicest beaches in your opinion?
Oh man, that's a really hard question.
Yeah, tons of them, right?
Yeah.
I've heard that northern Brazil are nicest.
Yeah, here specifically in my state, if you go north by the coast, you're gonna see a lot of beautiful beaches, especially in the upper states like Pernambuco, Ceará, Rio Grande do
Maceió.
Norte, Maceió. Wow, there are so many beautiful beaches.
Pessoa.
It's yeah, it's
Let
amazing.
me get a map here.
No problem.
I want to see this. From an insider.
Oh, right there.
Fortaleza, north of Fortaleza,
Yeah, a little bit south from there. This is very in the north.
Natal.
Yeah, do you see Maceió over there? You can go a little bit more, a little bit to the south,
Marcelo.
a little bit south from there. There's Aracaju, a city over there, and we're almost approached Bahia. Yeah, this is Sergipe, another a state, a little bit in the south. There you see Salvador, right there at the tip.
Yeah. So that's the best beaches. Some of the best beaches in Brazil are here, huh?
Yeah, by that coast over there.
It doesn't, is it developed this coast or no? Is it empty?
No, there are plenty of beautiful cities over there.
Yeah. Of course, that's a long drive from Rio to Salvador.
Yeah, it's a long drive.
Now you guys are in Corita, right? Here? Are you in Corita now? Oh, you're in
No,
Salvador. You're in
I'm in
Salvador.
Salvador. Yeah. I did
Okay.
my training in Curitiba, actually.
Okay. And that's where Dr. Barber's at, right? Corita?
Yep.
Okay. A couple hours from Sao Paulo.
By flight, it's about 40 minutes.
A good size. It's a good size, right? Oh, okay. I'm getting the city's floor, Minneapolis. So whenever you fly internationally, you got to come through Sao Paulo or
Usually
Rio.
Sao Paulo or Rio.
Yeah, to go to Curitiba. Yeah. Not many direct flights, right, internationally. Okay, we're getting a few people now, finally. There's a couple of people coming in, I'm sure one of them is a resident.
Hey John, how are you doing?
Hello,
Hey,
Pedro,
Doctor. How are you doing?
welcome. And Dr. Sokolovsky.
Yes, hello.
Oh,
Here.
you're here. Oh, good, you're here. Okay, great.
Are you?
Okay. I guess Leandro's going first, right?
Yeah. Hi,
Right.
Dr. Soklovsky. Good to
Hello,
see you.
Leandro. How are you? Good to see you.
Good. Nice.
Happy to join.
Thank you.
Alô? Alô? Alô?
It's 19 hours.
Okay, I guess I just sent Dr. Barber a note. Haven't heard back. So I guess, Paige, are any other residents here or no?
Yeah, Pedro is one of the residents.
Yeah, I'm here, but the others are just joined now.
Okay, I'll introduce Leandro. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good afternoon. This is Dr. John Bennett broadcasting from beautiful Miami Beach, home of Neurosurgical TV. We have another neurosurgical grand rounds from Hospital Mackenzie. And I'd like to introduce, we have two webcasts tonight. The first webcast, microsurgical anatomy of facial nerve with Professor Leandro Bova Moreira, MD from Salvador, Brazil. Welcome, Leandro. It's all yours.
Hello, John. Hello, everybody. Thank you. Good night, everybody. So, my name is Leandro. I'm a neurosurgeon here from Salvador, Bahia, from Brazil. I'm Professor Borba's former resident. And after I finished my training with him, he really encouraged me to go to the USA to go for a fellowship. So that's what I did. I spent 2 years at the Barrel Neurological Institute in Phoenix, Arizona. I spent 2 years there, and after finished my research training there, I came back to my hometown, and that's where I work now. Can I share my screen, John?
Yeah, sure.
Let me just hold on. Share. Share. Can you see my screen?
Yes.
Yeah.
For presentation mode, bigger. That's perfect.
How about now? Yeah,
Sure.
is it working? Okay, perfect. All right. So this is the main hospital that I work here in Salvador, Bahia. It's my father also is a neurosurgeon. He works at that same hospital as me. He has been working there for over 33 years, I guess. And after I came back from the fellowship, I started working there too. And it's a real privilege to me to work at the same hospital as him. And I actually work with him, and we do some cases together. And that's a real privilege. And today, I'm going to talk a little bit about the microsurgical anatomy of the facial nerve. Let me just try to put this. Yeah. The microsurgical anatomy of the facial nerve. My lecture is going to be purely anatomic, and Professor Sokolovsky will be talking about cases later. And let's go. Let's start. Let me just. Can you see my mouse here, my cursor at the screen?
Yes, perfect.
Okay. So when we're talking about the facial nerve, we all know that it's a very important nerve. And why is that? Because of the main function. It makes the mimics of our face, right? So that makes us smile and our expression and so on. So that's why when we have an injury of the facial nerve, whatever kind of injury is that, inflammatory, traumatic, by a tumor, the cosmetic appearance is going to be very explicit in our faces to the patient. So this can cause especially a social problem to the patient because of these cosmetic. It's the first thing that we see when we meet a person. It's their expression, right? So when we're dealing with some lesions that affects the facial nerve, it's really important for us to understand the anatomy, the microsurgical anatomy of the nerve, to try to avoid injury to that nerve if it's not injured already. So many surgeons deal with the facial nerve, not only neurosurgeons but also plastic surgeons, ENTs, head and neck, and we all have to keep this concept in mind about the social problematic that can cause by a traumatic facial nerve. So I'm going to start the presentation introducing this classification that was made by House Brackman in 85, I guess. And it's only a classification of the facial weakness, and it's grading from 1 to 6. Grade 1, it's the normal movement of our face, and grade 6, it's no movement at all at one side of the face, the completely palsy. And in between, we have different levels of weakness. And we can use all of these classification preoperatively, post-operatively, to compare how is the patient, and after a surgery, the procedure, how is the patient is dealing, and if it's getting better with physiotherapy or whatever treatment the patient it's doing. So we use it's worldwide use that classification grading system. Okay, so we have the intracranial part of the facial nerve and the extracranial part of the facial nerve. For the extracranial part of the facial nerve, the exposure of the extratemporal part of the facial nerve, it might be necessary, as I told, for procedures that involve the cranial cervical junction, like parodonticectomy, globus jugularis tumors, hypoglossal-facial anastomosis, and other pathologies that we can deal in this area, metastases. And there are actually two types of techniques that we can use to identify the facial nerve extra cranially. The intraoperative identification of the facial nerve is crucial, as we saw, just to avoid lesion. An early identification of the nerve is crucial, so the surgeon must be prepared. And we can use some anatomical landmarks that guide us to identify, especially the extratemporal portion of the facial nerve. I know that we have actually the technology by our side nowadays. We can use intraoperative monitor electrophysiology. You have a neurologist inside your OR making all of the detection of the nerve and so on when you're operating. But this is not the reality for all the places, especially in developing countries. Not every time you have a procedure, you have this technology that you can apply in the OR. And I would dare to say sometimes, even in private practice, it's hard to get one of the monitoring intraoperatively. So we have to understand the anatomy. And if we add our knowledge to technology, it's perfect. If you only rely on the anatomy, well, it's of course going to be better for the patient in the outcome. Excuse me. There are basically two techniques to identify the extratemporal facial nerve: the anterograde, so identification of the facial nerve trunk. The facial nerve trunk, it's the segment egressing from the stylomastoid foramen until the bifurcation at the parotid gland. So this is a tiny segment that we can identify early during surgery. If you identify the segment, at least you know where the facial nerve is. You can be more aggressive in your dissection, whatever pathology you're treating, and continue your surgery. The retrograde fashion, it's more like an identification of a tiny distal branch of the facial nerve and follow that tiny branch to its origin at the trunk. This might be a little bit tricky because these branches, they are really, really tiny. Even when we're using a microscope or loops, sometimes it's really hard to see those tiny branches. All right, so moving on, before we go to the extratemporal part, let's start with the intracranial part. So the intracranial part of the facial nerve, it's divided in multiple segments. And we're gonna go over all of these segments one by one. The facial nerve nucleus, it's in the brainstem, and it's located here, where I highlighted at the floor of the fourth ventricle. So the nucleus is going to send the origin of the intrapontine segment. It's going to be the very first segment of the facial nerve. It's going to make a tiny loop around the sixth cranial nerve nucleus, and it's going to go laterally. And it's going to origin from the brainstem laterally, like this, at the pontomedullary junction in the pontomedullary sulcus, as is highlighted over there in this specimen. We can see that the facial nerve, it's lateral to the abducens nerve and anterior to the auditory nerve. That is pretty close to the facial nerve. Moving on to the next segment, excuse me. This is a retrosigmoid view of a cadaver dissected. Here at the CP angle, probably the retrosigmoid approach, it's one of the, it's a very well-known approach for maybe all of the neurosurgeons, because probably is going to be the approach that we usually use and perform to treat lesions in the posterior fossa. And here we can appreciate this bundle of nerves here that are going to the jugular foramen. These are the lower cranial nerves. And here we have another bundle of nerves that it's mixed, the 7 and the 8 complex of cranial nerves. And also we can appreciate this big vessel over here that it's looping around the nerve. This is usually ICA, and there's a clinical importance with that, because when the patient is presenting with hemifacial spasms, Usually there's a conflict of these artery with a nerve, and it's usually ICA. And we actually use this approach to do these microvascular decompression and put the Teflon cushion over there from the artery to the nerve. So we separate and the patient gets better in the post-op. So that's the clinical implication of that. And we have to know the anatomy. And here we're going to the second segment of the facial nerve that already egressed from the brainstem, and it's running from the brainstem to the IAC, that is here superiorly, at this part over here, this little drill. Another thing that we have to note about the anatomy is because of this bundle of nerves, when we're treating lesions over there, especially vestibular schwannoma, that is intracanalicular, extracanalicular, we have to keep in mind that all of these anatomy is going to be distorted, and it can get us a little bit confused. So there's this little mnemonic that we use usually to understand the anatomic position of this bundle of nerves via a retrosigmoid approach. That is, the 7 is up and the coke is down. What that means that the 7th nerve, it's up, it's anteriorly, superiorly, and the 8th cranial nerve, the cochlear nerve, the auditory nerve, it's down, it's posteriorly. So for the residents, this is also relevant because this is one of the board, it's one question of the board exams. They love to ask for that kind of a perspective in the anatomy of the nerves via this approach. Now moving on, we're pointing towards the IAC that has been drilled over here to expose this model of nerves. I'm going to highlight the facial nerve over here, and we can see that it's anterior and up the facial nerve, even in the intracanalicular part. Here is the cochlear nerve, the auditory nerve. This is the superior vestibular nerve, and that's the inferior vestibular nerve. The inferior vestibular nerve has been cut here and reflected posteriorly, just to show this bundle of nerves here is inside the canal. We can also hear another segment of the loop of the ICA. The next segment, it's going to be going toward the IAC at the top. The facial nerve is going to go to the facial canal. So the next segment, it's the labyrinthine segment. It's a very tiny, thin, and very fragile segment of the facial nerve. And this tiny segment, it's in between the tympanic part and the labyrinth. So this is a very tiny segment we're going to see later on. I just want to highlight here this tiny little branch that is this part of the nerve that it seems to be branching from the facial nerve. This is the intermedius nerve. It's really hard to see in real surgery. We actually don't see that much, but it's here just to highlight that it's a nerve connected to the facial nerve. It carries some parasympathetic fibers to the facial nerve. It's going to go to the sphenopalatine ganglion, and it's going to make its function right over there. Moving on. So we're now at, this is another cadaver on the left side. This is a mastoid completely dissected to expose the next part of the facial nerve segment. That is going to be right this one. This is the next segment after the labyrinthine segment that I talked before. That is the tiny. It's really hard to show. And this segment right now, it's the geniculate ganglion. It's a very important structure because the geniculate ganglion it's a genu. So it's the facial nerve makes this posterior curve from its meatal segment and turns posteriorly to the mastoid. And before we advance to the next segment, I'm going to talk about a little branch that it comes from the geniculate ganglion that is not coming posteriorly, actually travels anteriorly. That's going to be this tiny nerve over here that I'm going to highlight. This is another view. This nerve that I highlighted is the GSPN. We all know what the nerve is and why is it there. this is a view a position, especially that we're going to operate on the middle fossa. We do the peeling of the middle fossa. We're going to work here at the cavernous sinus, or here at the at Kawasi, or in these structures over here. And whatever the pathology is over here, we have to be very careful when we're dealing with the peeling of the middle fossa. Here we have the GSPN. Usually is on top of the picture segment of the carotid. So here we have V3, ovale, spinosum, MMA. So these are all landmarks that we identified there. So we have to be very gentle when we're doing the peeling, separating the two members of the dura, because we cannot stretch that nerve very much. And why we cannot stretch that? Because as we saw, it's coming from the geniculate ganglia that is attached. It's a part of the facial nerve. So if you stretch this little nerve too much and working in an area over here, you're not even dealing with a facial nerve over there, the patient might have a facial weakness or palsy in the post-op. So you have to be very careful when you're dealing with that. We have to keep this in mind. The GSPN is going to travel anteriorly. It's going to meet the deeper petrosal nerve anteriorly. Also, they're going to form the median nerve, going to go to the median canal. That is also a canal, and the median nerve, it's also a landmark that we use through actually endonasal approach, using an endoscope to help us identify the carotid when we're doing endonasal surgeries. Okay, moving on. Next segment of the facial nerve. Now we're going to talk about the tympanic segment of the facial nerve. We can see here highlighted, that's the tympanic part. And it's in a very close relationship with the lateral canal. It's side by side with the canal. And this is also a tiny segment. And we can notice this tiny bone over here. That's the incus. When we're doing a mastoidectomy, for whatever reason, you're operating at this part, you're going for a petricalivus meningioma, you're doing the drilling of the mastoid, you'll drill here the antrum, and you find the incus. You don't need necessarily to expose the incus, but you know where it is. Notice that the short process of the incus is pointing toward directly to the facial nerve. So we can use this as a landmark, as this is a bone. This anatomy is almost always constant, so it doesn't change. So this is one of the strategies that we use to know at least where the facial nerve is when we're dealing with the drilling of this area over here. The next segment will be the last intracranial segment. It's the mastoid segment. This is all covered by bone, mastoid air cells. And again, remember, we have to keep in mind, we don't necessarily need to expose all of these of the facial nerve, depending on what you're dealing, the approach that you're performing. Unless you need to manipulate the nerve, of course, then you have to skeletonize and dissect all of the nerve and be careful. But if you're just doing a mastectomy for an approach or treat another pathology, we have to keep in mind where the facial nerve is. We can use all of these strategies of the landmarks, but we don't necessarily need to expose the nerve. This tiny branch over here coming from the mastoid segment is the chorda tympani. It's going to go posteriorly, anteriorly, going to round here the tympanic, and it's going to go, and it has some sensory fibers to the anterior 2/3 to our tongue. That's the function of this nerve over here that is branching from this segment of the facial nerve. And when we're dealing with this kind of approach and dissections, we're going to use the landmarks that we know. So when I dissect, we identify the sinuses, the petrosal sinus, transverse sigmoid, the jugular bulb. We expose all of these areas. We know what the labyrinthine is, the canals, the superior, lateral, and posterior, and keep in mind where the nerve is, especially with patients that has no facial nerve deficits. So here are the canals. Here's the incus, the short process. That's the facial nerve and chorda tympani. Now moving on to the extra cranial part. As I said, we're going to use landmarks, right? So most of these landmarks, they are going to be solid structures. like bone, cartilage, and also we have some soft tissue like muscle, tiny branches of nerves, and tiny vessels. So if we use at least 3 or 4 of these landmarks, we can guide ourselves when we're operating on that area, the craniovertebral junction, try to predict where the facial nerve is, find it, dissect, and keep it safe. So just to illustrate, this is the left side of the dry skull. So here we have the mastoid and the tympanic part of the temporal bone. If you watch closely, they create a little fissure over here. That's the tympanic mastoid fissure. That if you follow this little fissure inferiorly, it's going to lead exactly toward the stylomastoid foramen right over here. If you trace like this, you can see where the facial nerve is going to be egressing. When you're doing surgery, you can try to dissect a little bit this area over here, and this is going to be a good landmark. The styloid process is anterior and more lateral to the facial nerve. The mastoid is more posterior and medial. The AAC here. This is another cadaver with another exposure, the craniovertebral junction to the left side. And here, the facial nerve is all exposed and dissected. I'm going to highlight here. And we have basically all of the segments that I just talked about. Here we have the cisternal segment. You can appreciate here that the labyrinth has been all drilled just to expose the nerve. The cisternal segment is over here, the meatal, labyrinthine segment, the geniculate ganglion, the tympanic part, then the mastoid part, and then it comes inferiorly. And at this point, it's going to be the stylomastoid foramen that we just saw, and the facial nerve is going to be egressing from here. And this segment here, as we talked by the beginning of the lecture, that this segment from here to here, it's going to be the facial nerve trunk, right? So it's going to be right here, this extra temporal part. The parotid gland, it's something around here that is being completely dissected just to show the other tiny branches are going to branch all over to the side of our face. So you can see that the trunk sends some smaller branches over here. We're going to see. This is the digastric muscle we can use as a landmark, as we saw, but remember, this is a soft tissue. We can mobilize this too much and not necessarily be, it could be close or far from the facial nerve. You have to keep this in mind. The tragus pointer, it's the tip of the cartilage of our ear. It's pointing toward the trunk as well. This is the posterior auricular nerve, as we said, is a branch from the facial nerve that comes anterior and goes superior, innervates these tiny muscle over here, the auricular nerve, that some people will have the ability to move the ear. It's because of the innervation of this tiny muscle over here. The PAA, it's this tiny branch of artery over here. It's a branch of the external carotid artery. It's not a very reliable landmark, but it's kind of a close to the facial nerve. As I said, some structures that are more mobile and soft, we have to be very careful because these anatomy can vary a lot. So in some patients, it might be closer to the trunk. In others, might be farther. So we have to keep these in mind. But there's another branch over here, the SMA, the stylomastoid artery, also a branch from the external carotid artery. If you follow this tiny branch superiorly in this area, you can see that this tiny branch is entering the stylomastoid foramen over here. So when you're dealing with pathologies over here, if you find this tiny artery, you can follow it superiorly. This is also going to be a landmark to try to find the facial nerve trunk. And you can rely on that. So just to illustrate, one of the papers that we published, it's exactly about that. It's a tiny branch that is coming from the trunk that goes to the digastric muscle. And we call it the digastric branch of the facial nerve. Excuse me. And we use these exactly to add more another landmark to the surgeon when it's operated at this area. If you gather more landmarks, just to help the surgeon to identify early these the trunk of the facial nerve. So here it's also the left side of a cadaver. This is a sternocleidomystoid muscle that has been reflected posteriorly over here. And this is the digastric muscle, PAA, the stylomastoid artery that is going superiorly to the stylomastoid foramen, and the facial nerve trunk is over here. And this tiny little branch, it's what we call the digastric branch of the facial nerve. Again, you have to keep in mind, this is a soft tissue. This is very mobile. The anatomy usually is distorted here. Depending on the pathology, this tiny branch can be completely compressed. There's no problem to injury this tiny branch over here, but all we have to do is try to identify that branch. It's going to help the surgeon follow it superiorly, try to find the trunk. You can injure this tiny branch, just don't injure the facial nerve trunk. This is only a case to illustrate. There's no surgical steps over here. That was a vestibular schwannoma of one of the very first patients that I operated when I came back from the fellowship. So one of the first cases that I performed without any supervision of my mentors, and I gather all of that knowledge that I learned from Professor Borba during residency, during training over and over at the lab, and perform this surgery. This is the MRI at the post-op. It was a good resection, a total gross resection, and of course I got the consent of the patient to show here in the presentation. And this is the patient 3 months in the post-op. Of course, she had lost completely her hearing on the left side, but her facial movement, her facial nerve was intact. So in the post-op, we have a little bit of weakness on the left side. This is 3 months post-op. And now it has been over 3 years that I have operated on her. She went to physical therapy, and more than 3 years now. I often see her. She goes to the office to follow up, and she's doing great. She went there from I will say a grade 3 to a grade 2 now, and almost grade 1. So almost completely recovered that little deficit in the post-op. So that's it. I would like to thank Professor Borba and all of your organization, and for the opportunity to tell you a little bit about this lecture of the facial nerve, and just to leave a message for the residents over here. If you have the chance to train more in the lab, I know that Dr. Borba, it's always encouraging us to do that. I strongly recommend you to do that, because it's going to have a huge impact in the future, especially in our patients. And thank you, everybody. If you have opportunity to go there to Curitiba to meet Dr. Borba's facility lab to train, is for free. There's always been courses. I had the opportunity to go there twice, and it's amazing. That's how I think we can make the difference in the future, especially for our patients. Thank you.
Thank you, Leandro. Thank you, Leandro. No, Leandro was our resident, and he's Borba also.
Yeah.
I received several messages asking me, your son you talking today. Says, I will. He's a great guy. Could be. He's a great guy. Leandro trained us here in Curitiba after he went to the Barrow, and spent more than 1 year studying anatomy, watching surgery, doing a lot of papers. Now he's in Salvador. He's doing a wonderful job. The anatomy of the facial nerve is one of the very, very important issues when we discuss about neurosurgery. But more than the anatomy itself, there is a lot of tricks to understand and to treat and to how to manage the facial nerve. And the facial nerve management is not only the surgical approach, not the neurological approach, but also the rehabilitation. I think Mariano, you talk about this later, but today we see a lot, especially in Brazil, physical therapists, every kind of technique, and sometimes the physical therapy makes the patient worse than it was before. And this one of the situation. Before, the intraoperative monitoring was very extremely important to understand the anatomy of facial nerve. Now that we are using very common the intraoperative monitoring, the people is missing, is not taking into care about the anatomy. Remember, the intraoperative monitoring can help you 100%. But if you know the anatomy, you know where you are. Leandro, let me ask you one thing.
Sure.
To identify the facial nerve in the before the parotid gland, the extratemporal part, always there is a vessel there. Is a constant vessel, or sometimes you don't have this vessel that's going around the. There is a trick they call pointer. I think Mariano can talk about this later. But anatomically, you can also see this artery in your dissections.
Yes, Professor. When it's one of the landmarks that we can rely when we're talking about vessels, because these are they can have different variations of anatomy, but it's almost constant to have this mastoid artery that is coming from the external carotid artery that is going to the stylomastoid foramen. Because this tiny artery, it's the one that irrigates all of this area, including the facial nerve. So we have to be careful with her. I think that's the artery that you're referring to, and I have really good memories, and especially when I remember you performing a case, and you talked specifically about this tiny artery, and that I kept that in mind. I don't know, it's imprinted there in my mind. So yeah, and so I think that's the artery you're talking about. It's a small artery, but we can rely on that.
Okay. And inside the temporal bone, there are some tricks to find the facial nerve. Have the incus. How you say in Spanish? In Portuguese is a bigorna, incus. The short arm is pointing to the facial nerve, just anterior to the lateral semicircular canal. It is very, very important to do. And the other trick that sometimes you use when dissect the temporal bone, when you dissect around, a lot of irrigation, and we start to bleed a little bit. Go away, that maybe the facial nerve is in our way. Okay, thank you, Leandro. I think a great pleasure to us to have Professor Mariano Sokolovsky. Mariano is a neurosurgeon from Argentina. Mariano is one of the most recognized neurosurgery in the field of peripheral nerves. If I start to say about his CV, how things he did. But first, I would like to start, thank you, Mariano, especially for the support you gave to our residents. We have three or four residents in the last year of they went to Buenos Aires, stay 6 months, 3 months, 1 month, 1 year with Mariano, and learn a lot. And many, and all of them, and many of these young neurosurgeons that went to Buenos Aires, they came back to Brazil. Now they are doing peripheral neurosurgery. And they are working together with the people of other parts of the country to bring back the specialty to the neurosurgery. And we are our mentor in whole Latin America, in the world. Thank you very much, Mariano. Thank you very much. Please go ahead.
Thanks. Thank you. Thanks to you, Luis, my dear friend. It's a pleasure to of course, to collaborate. It's a big pleasure to see patients operated by young neurosurgeons, and the results are wonderful. So that makes the stimulation of peripheral neurosurgery much bigger, and it's the task that we have at this moment. Thank you again for inviting me, Dr. Luis, my dear friend, and also to Dr. Bennett. And I want to say thanks also to Leandro, because he really make my life easier talking about anatomy before my talk. So I want to share the screen. Let's see if I can.
Can you do?
Yes, just a second. Let's see if I can see what's going on.
You have the option screen share. You see it?
Yeah, this is a new computer, and this is the first time I talk with this
Yeah,
computer.
I know,
Sorry
that's
for
what,
this.
that's what happens. That's what happens.
Mariano, intenta buscarle donde dice compartir pantalla, ¿no? La partecita de abajo, media verde.
Sí, ya puse y no me... Ah, hola, Byron, ¿cómo te va?
¿Qué tal, Mariano? ¿Cómo estás?
Y no me está dejando, dice, abrir preferencias del sistema, seguridad y privacidad para obtener acceso. A ver, seguridad y privacidad. Acá está. Ok. I'm very sorry for this. Let's see if I can do it. Otherwise, I will look for my old computer.
Tu puedo mandar su PowerPoint a otra persona para presentar. Si tú quieres.
No, I think I've done it.
Okay.
Let's see if I can do it now. Oh, he asked me to go out of the Zoom. Okay, sorry. I'm going to do it as fast as possible.
Okay, let's start to talk about something. There is, when you do surgery in the facial nerve is the big issue. And the most common tumor is the acoustic neuroma. Today, when the people talk about vestibular schwannoma, they are talking about hearing preservation. But still, the facial nerve is one very, very important issue in surgery, the vestibular schwannoma. But now is coming back. A lot of cases that we are doing surgery in the brainstem. See, for lesion in the brainstem. I have Dr. Paulo Cadre here. He is in one of the panelists. See, he has one of the most beautiful dissection of the facial nerve and dissection of the floor of the brainstem. What's the trick to find the nucleus of the facial nerve in the brainstem without stimulation? Without stimulation, with stimulation, I can find also. To see if anatomy.
I would say that in the floor of the fourth ventricle,
Okay.
the most reliable landmarks that you have are first the midline and then the medullary striatus. And then you know that the facial collicula is just above it.
Above what?
Right? Above the medullary striatus. So the medullary stria and the midline, it's not usually, most of the time, it's not difficult to recognize. So then you know that just above it, you might find a small pump, and this is the facial collicular, which is actually the sixth nerve nuclei, right?
But how many millimeters from the midline?
I can tell
Is
you
it the
that
midline or lateral?
it's not reliable. It's a little lateral from the midline, right? In the midline, it's the longitudinal, the medial longitudinal fascicle. That's right in the midline. So exactly millimeters, because there is always variation. There is rhomboid fossils that they are very large. There are some that they are very stretched. So it's not really reliable, like 1 millimeter above, 2 millimeter above. But you can really see the medullary striatus, you can see the midline, and you can see usually that elevation in the medial eminence, that is the facial collicular. If you look careful, and if you have a good anesthesia, and if you have a good exposure, you can see that.
Okay, see the gentleman, Mariano is ready.
Okay, Mariano is back.
Again,
Mariano,
sorry
please
for
go
the
ahead.
inconvenience. Yes, sorry
Gracias.
for this.
Tranquilo.
Okay.
Gracias.
So, well, as you know, facial nerve palsy needs a very good donor. The best donor for facial palsy for reconstruction is the same facial nerve. This is important to remember because many people does just hypoglossal to facial, or masseter to facial or whatever, but remind that the facial nerve is the best donor that you can have. And you can see, for instance, this patient who had a complete palsy after a lacerating trauma of the face, and you can see how the complete palsy is caused by this lacerating wound, which was repaired, and you can see upper right the section and upper left and lower left the repair with grafts, with interposed graft. So the result of this type of reconstruction is quite good because the patient can move spontaneously, have a spontaneous smile, spontaneous eye closure, and so on. So again, the natural result of this technique is very good. And remember about the facial nerve. So wherever you do, as Leandro showed, very nice exposures of the facial nerve. If you can reconstruct the facial nerve like this, or many other places where you can do it with graft or via a direct suture, which is, of course, more difficult to find. Anyway, this type of reconstruction has the best technique. But, as you know, the hypoglossal facial anastomosis is very classical. It has more than 120 years. You see, it's very, very old. It's a very classical technique. And basically, you have to cut completely the hypoglossal nerve and put it into the facial nerve in this way. So this is a direct suture, and the hypoglossal nerve, as you can assume, is very, very, very strong. So the results of this technique are very good. And you can see here the typical result of a hypoglossal reconstruction with to the facial nerve. And you can see lower right that the patient has a very severe hypoglossal nerve palsy with atrophy of the hemitone. So this is expected if you cut completely the hypoglossal nerve. How can we minimize this morbidity related to the complete section of the hypoglossal nerve? Well, I'll tell you, it's not really necessary, and I will show the proofs of this thing. I will show that it is not really necessary to section completely the hypoglossal nerve. You can section only 1/3 or maybe 1/2 of the nerve, and that's it. So there are some alternative techniques described for facial renovation without sectioning all the hypoglossal nerve. The first one, and the most used by us, is the so-called Sawamura or Ferraresi or Atlas. Many people at the same year, this is real, at the same year, 1997, described this technique. So there are some alternatives, basically, of drilling of the mastoid portion of the facial nerve and put this facial nerve, the longer facial nerve that you obtain if you drill the mastoid bone into the hypoglossal. But you have to put half of the hypoglossal or maybe 1/3 of the nerve into the facial nerve. The results of this technique are comparable in terms of facial reanimation. This is pre-op, and this is post-op. A good result, good symmetry, good smile, good eye closure. And if the patient shows the tongue, you will see that there is no big atrophy. You see? You see that the tongue is really mobilizing the face, because when the tongue goes out of the mouth, the eye closes. So there is a synchronicity, and this is a proof that the hypoglossal was used. And even although it was used as donor, we use only half or 1/3, and that's why we obtain a good, less morbidity of the tongue. You can see here, pre-op, post-op, again, same results, good symmetry at rest, more cases, pre-op, right side of screen, left side of the patient was paralyzed, and this is a result with good symmetry. Fortunately, when we speak, we move the tongue and we also move the face, so that makes things easier, because the patients, when they speak, they look very natural in terms of face movement. You see? Pre-op, post-op, and so on. Again, pre-op, post-op. In an old lady, near 80 years old, this technique is so good, so strong, that it still works. So we presented our cases some years ago, I think it was a decade ago, with Roberto Martins and Mario Siqueira from the University of Sao Paulo. And again, more cases showing this technique. You can see how the results are good in terms of symmetry of the lower part of the face, eye closure, and so on. Maybe one critique that we can do to this technique, and we have to tell our patients about this, we shouldn't avoid this thing, is that usually the spontaneous smile is not possible to be recovered with this technique. Why? This is logical, because the hypoglossal motor cortex, primary motor cortex of the tongue, cannot move spontaneously the movements of the face, which of course are linked naturally to the limbic system. But the limbic system, which is involved in the emotions, is not directed to the motor part of the face in terms of the tongue. So this is after telling this patient, the same patient that I showed before, a shock, you can see that her spontaneous smile is only 1/2 of the face. So this is a limitation of this technique. And even though our patients are very, very satisfied using hypoglossal to facial, they have to be informed about this thing. So brain plasticity is limited. The brain cannot create a new connection. It just uses pre-existing ones. Do we have other alternatives? Yes. We have, for instance, using an interposed graft. As you can see on the left of the screen, the two nerves, and in the right, if you have, for instance, a problem in the mastoid and you cannot use the long mastoid segment, well, then you can use a graft. And this technique also was described as a jump graft by Mark May in 1991. Also, it has a long history. The results of this technique are not so good, This is pre-op and this is post-op. We feel that the symmetry at rest is not so well achieved as the other one. So that's why we prefer to use the complete, the hypoglossal with mastoid bone drilling. you can see here an excellent result of this technique, but be aware that we should use videos. This is the same patient, postoperative video, and you can see the result was not so good. But I can cheat. I can cheat, and I can ask the patient to move the tongue into the palate, and the patient will move as you see. So be careful. Be careful. When you see results of facial reanimation, try whenever you can to show videos, because with video you can see a spontaneous movement or natural movement during speaking or taking out the tongue of the mouth or whatever, much better than with photos. And last but not least, we have the masseter to facial anastomosis described by Ronald Sacker from Canada in 1989. So using this masseter, which is very strong as the hypoglossal, we can reach part, not usually all, the facial nerve, because the masseter is a smaller nerve. So here you will see before surgery and after surgery. Again, good reanimation. In this technique, contrary to what happens many times with the other technique, with the hypoglossal, you might need to help with a secondary surgery for eye closure. This is a patient from Dr. Roberto Martins and Mario Siqueira, pre-op and post-op. And this is another patient pre-op and post-op with the masseter technique, using masseter as donor. So what's the best method? I'm speaking about hypoglossal, hemihypoglossal, hypoglossal with graft, masseter. So we did this comparison study some years ago, was published in 2018. And you can see that we compare all the techniques, and we saw that the results were better using the masseter, but also using the hypoglossal without graft. If you use a graft, you obtain a worse result in terms of facial symmetry and in terms of many other variables that we analyze. Again, regarding the results, please take into account the results go down. They start to go down around the month number 12 after the denervation, and then goes on going down. And after 2 years, or maybe some months more, it is not worth to do the facial reanimation, and you have to go towards secondary procedures. Again, more results extracted from this article showing the same. There is a statistically significant difference for hypoglossal to facial if you don't use grafts. Same for masseter. There is a time factor implying these results, and also the number of axons. And if we analyze, the more axon you give to the facial nerve, the best result you get. But you don't have to give more axons than the facial nerve. Otherwise, you are sectioning too much hypoglossal or whatever nerve you use as donor. So this was proved also by Ronald Sacker and his group, Greg Borchell also, saying that facial reanimation depends on donor motor nerve axon density. So in cross-facial, we usually do not obtain such a good result. And to finish this presentation, I want to show you an 8-minute duration video showing the technique that we actually use at this moment for hypoglossal to facial nerve reanimation. As I said, Leandro made my life much easier showing these the wonderful anatomical preparations that he has done. So you can see here the mastoid bone drilling. And as Luis said, there is a very very classical anatomy. We are taking out the incus here, also described by Leandro very nicely. And of course, you can take out the incus and you can get more proximal if the patient has not hearing preservation. We go on dissecting the mastoid segment. We change to diamond boards. And here we are sectioning the nerve in the tympanic portion, very distal in the tympanic portion. And then we take out the nerve from the nerve duct. We are near the stylomastoid foramen. And now it comes a very important part of the, no, I'm now dissecting the hypoglossal nerve. So you see here the digastric muscle that was shown before also. And below the digastric muscle, the posterior portion of the digastric muscle, we can find very easily the hypoglossal nerve. Under stimulation, we detect the nerve. We go first distally to get more room in order to make the nerve transfer, as you can see, and then we go more proximal. Remember, the more proximal you go, the more medial and the more deep gets the hypoglossal nerve. And now we are starting to go back to the facial nerve. Please remember this. It is much better to see and detect the facial nerve if we go extratemporal into the parotid gland. So that's what we do now. And this is the facial nerve entering the parotid gland. You see here, we are opening exactly at this moment the stylomastoid foramen. The adherence of the facial nerve here to the foramen is very strong. So this is the most difficult part of dissectioning of the facial nerve. We are dealing with the artery that Luis just mentioned, and we go on opening the structures. And as you can see, we can work very safely if we obtain the extratemporal facial nerve entering the parotid gland. Otherwise, it's too dangerous to work just with the proximal stump. Okay, so you look at this. We are taking out the nerve of the mastoid foramen. And here we see the branches that were also mentioned. Branches that go to the digastric muscle that we don't need to reinnervate. And also, we have to cut. Otherwise, the nerve will not reach our donor, which is the hypoglossal nerve. Now, it's almost done. You see the facial nerve almost completely free. And here we are rerouting the nerve from the upper part to down into the, you see, here it was, this is the natural position, and we are rendering it downwards into the hypoglossal nerve. You can see how easy they get together, the donor and the receptor. We go on dissecting distally the hypoglossal nerve. You will see, I think in this video, you will be able to see the ansa hypoglossy. Yes, over there. You see? That's the answer. And as I said, we move more proximal. You know what we are sectioning? We are sectioning the digastric muscle, the posterior belly, of course. So you can see how easily it gets. It's important to section that muscle. Otherwise, it's dangerous with the construction, with the ventral contraction of the muscle, which is, of course, paralyzed. Now, this is another important step. Look at here, we are dealing with the epineuron of the facial nerve. Why it is important to take out the epineuron from the facial nerve? Because the facial nerve is much thinner if we take out the epineuron. A thinner nerve requires less axons from the donor and less morbidity in the tongue. You see how thin it gets if you take out the epineuron. And now we are working with the hypoglossal nerve. At this point, we will select fibers coming from the main trunk, which is that one. Okay? There are different maneuvers we can use in order to obtain just the part of the hypoglossal. This is the one that we prefer with the forceps. Of course, not a very microsurgical forceps, but we can obtain this length of and this width of the nerve, and we are ready for nerve suturing. We put a shell foam beneath our nerve suture. We put a couple of stitches. Of course, we don't have epineuron here. As you saw, we took it out from the facial nerve and also from the hypoglossal nerve. So these stitches are usually 10.0 nylon atraumatic stitches. We only put a couple, not more than 2 or maybe 3 in certain cases. And that's it. All this mess was also only necessary to put a couple of stitches. When we leave, we put some firing glue. And that's it. So, concluding, direct hypoglossal to facial nerve and also using the masseter are better than using graft. The patients are almost always very satisfied. The rate of success is extremely high, more than 95%, and the surgical techniques are not very complex, as you could see. Other group, of course, prefer other surgical techniques like free grafts and so on. So thank you very much for your attention. And that's it.
Thank you very much, Mariano.
Thank you.
Wonderful presentation. You see, Leandro has his hand already raised. And let's start. We have here Professor Juan Luis Gomes Amador, Luis Felipe Alencastro, Byron Salazar, Professor Sebastián Guzmán. Thank you, Professor Guzmán, to be here. Let me start, make one question for you that everybody want to know.
Yes.
We have acoustic neuroma, okay? We did the surgery. We preserve anatomically, okay? The intraoperative monitoring say that is okay, but we lost 50%. 50% is okay. And the patient, the post-op has facial palsy. Okay? How long should you wait to do the reanimation? Because sometimes you spend more, you take more time, more than 6 months, and start to come.
Yes.
What's the value? The intraoperative monitoring, the neurophysiology intraoperative, what's the value of this when you do the the reanimation? I don't know if you understand what I said.
Yes. To give you a short answer, 1 year. Let me explain. we give a big value to the intra-op stimulation and also to the anatomical preservation of the facial nerve during the surgery, the primary surgery, of course. So during the resection of the CPA tumor. So if we see, or the surgeon that was taking out the tumor tell us that they saw the situation, that the hypothetical case that you just described, then we wait for 1 year. And in case that the reanimation is not present at 1 year, then we go to the facial reanimation. Why? Because as I've shown in the picture, the results start to decrease very strongly only at 1 year. Contrary to what happens to many other nerves, the facial nerve can be handled with a good outcome up to 1 year. We usually operate brachial plexus after 6 months, as much, probably before. But in terms of the facial nerve, the facial muscles can tolerate denervation for 1 year.
Okay, great. Leandro, please go ahead. You want to ask something, Professor Sokolovsky?
Yes, thank you for your lecture, Professor. It's a beautiful presentation. So I have two quick questions. The first was the same of Professor Borba, and how long shall we try to do the reanimation of the facial nerve, like at least 1 year? If there's any limit, like 2 years, 3 years, 4 years, is it still valid to try to do a reanimation, even for a traumatic lesion of the nerve? And the other question is there any difference if you do the anastomosis at the hypoglossal nerve after the ansa cervicalis at the bifurcation compared to before the bifurcation, or there's no, I mean, if there's any difference in the number of fibers that as you just mentioned in the ansa cervicalis more posterior of the hypoglossal nerve than more proximal?
Yes. First question, we tend to abandon the reanimation of the face via nerve surgery at 2 years.
Okay.
So in that case, we wait, the case that Professor Borba described, we wait 1 year for indicating the surgery. And then after 2 years, maybe a couple of months, okay, we can be flexible about that. Then we just give up the surgery. But remember, of course, if you have a complete section of the facial nerve during resection of the tumor, well, it's done. I mean, you wait 3 weeks or 4 weeks, and then you go to the surgery, right?
Okay. Mm-hmm.
The second question was very good, and I think I don't have systematical data on this, but our feeling is that where the facial nerve reaches the hypoglossal, either proximal or distal to the ansa hypoglossal, it's okay for doing the nerve transfer. So we don't care. Okay. We use the ansa hypoglossal as donor, for instance, to reinnervate the recurrent nerve for recurrent palsy. And it's a very strong muscle. It's a very strong nerve, sorry. So it's okay to use it. But in general, we use the upper part, not the lower part where the ansa hypoglossal branches. But this is, as I shown in the video, this is just a matter of technical issue.
Okay, thank you.
Thank you. Byron, want to ask something to
yes, thank you very much, Professor Borba. First of all, to congratulate Mariano and Leandro for these fabulous lectures. It's really important how they know their anatomy and how it helps us to really understand all the procedures that we want to do when these cases occur. I have a question for Mariano. For example, when you told us that you have a very difficult tumor and sometimes we tend to not cut on purpose, but there's an accident and you have this facial nerve accidentally cut the brainstem. You talk about the cross facial nerve grafting. So what would be your experience with that? Because I know that you sometimes use the branch of the trigeminal or the ipsilateral hypoglossal, sometimes the contralateral facial, or sometimes the spinal accessory. So I don't know what would be your experience in using the spinal or maybe the hypoglossal for those cases, and what's your rate of success? And the other one, when you feel that the anastomosis would be so tense, we know that we have to use another nerve. Do you use like the sural nerve? And if you use it, or the retromastoid nerve, what about the sizes of the nerve? Because sometimes the sural nerve is so big that I know that it will be a mismatch between the facial and the sural nerve. What would you deal with that? Thank you.
Yes, thank you. Regarding the last question, I would use, as donor for a graft, wherever nerve it's in the surgical field. We might be able to use the auricular branch, the posterior auricular branch of the cervical plexus right here. So maybe you can avoid going to the leg and taking out or harvesting the sural nerve. That is correct. It doesn't matter which nerve you use, it's the same in terms of the results of your nerve suture. Having said that, yes, of course, size mismatch of both stumps with the graft is something you have to deal with. And then, for instance, if you have the sural nerve, it's easy to make an internal neurolysis and take out the part of the nerve that you don't need. Because in the sural nerve, it can be done without any problem. And we usually need not very long distances of nerve graft to reconstruct the facial nerve. We just need short grafts, like 2, 3, 4 centimeters as maximum. And the first question also is very interesting, and as you might know, we are investigating very actively in brain plasticity. So our knowledge in brain plasticity can be applied to this issue, because if you use, for instance, the spinal accessory nerve, that's a very strong nerve, but when the patient moves the shoulder, usually it has spontaneous movement, which are not very nice. So this was described by as far as Harvey Cushing, where this was described by him actually when he went to a restaurant. You know, Harvey Cushing did this surgery very often, and he went to a restaurant and he saw his patient eating, and while she was eating, he was dealing with movements of the face. So he recognized that the spinal accessory was not very good. At that time, I'm speaking about 100 years ago. So you can imagine. Anyway, the masseter is a good nerve, and the hypoglossal is also a good nerve for being donor for facial palsy. This is because, as I said, when the patient speaks, moves the tongue, moves also the mouth, and moves also the face. So it's a natural plasticity in that term. By contrast, the cross-facial that you also mentioned, Byron, is a very good technique in terms of spontaneous recovery of movements, of spontaneous recovery of eye closure. But the branches are very tiny, they are very small, and they have to cross a long way to the other side. So the results of this technique, according to the literature, are not so good. We cannot reach 90% of good results like with the hypoglossal, with the cross-facial, at least according to the literature. Because I don't use it very much, because I don't like it as a donor, unless you have a very early palsy, like 2 or 3 weeks or 4 weeks as maximum, then you can reach a very good result. Otherwise, this is not our election for a technique.
Thank you very much.
Excellent. Mariano, if you have time, I have 10 questions for you. I was just...
I have to go to sleep at 3 a.m. Is it okay?
Okay.
3 a.m.?
Okay. First, there is a difference to use the sural nerve or the auricular nerve for reconstruction as a graft. There is some difference or not?
No,
I use a lot
no.
the auricular nerve. Okay,
That's a good technique. Absolutely.
That is in the field. Is there a difference to use sural nerve or auricular nerve or not?
Absolutely the same. You can use, if you are in the surgical field with a good auricular, which sometimes can be very, very, very thin. But if you have a good auricular, then go ahead. That's exactly the same.
There is difference between suture and fibrin glue.
Oh, very good technique. Very, very good question. You know, there was a study was made in rats, and they recognized that the results of using stitches and using fibrin glue are mostly the same. This is in the lab. In the real life, we prefer to use both. We use stitches and fibrin glue if we have. In that way, we can be sure that the nerve suture is good, because this is a one-shot game. If you lose your one shot, then you are done, because you have to wait for reanimation 6 months, 8 months, or whatever, and then it's too late for doing a redo surgery. So we prefer to use both.
And I had a video. I have a video of glomus jugulare that I removed the tumor. There is invasion of the facial nerve. I documented the invasion of the facial nerve. I cut proximal and distal. There is a gap. And I put the auricular nerve there. I put glue and cover with Surgicel. Okay? And Pablo Achler, that your friend from Argentina, showed me work that he did in the lab with rats, saying that if you put Surgicel, there is an inflammatory issue that the recovery will not the same. You
Yes.
agree, or is Argentina a guy that says something?
No, do not believe what the Argentinian guys said. Never. Anyway, no, I mean,
Yeah.
I do agree in some terms. It produces an inflammatory reaction, and of course, if we can choose, we don't use for wrapping this material. We prefer to use for wrapping maybe a vein or a muscle, okay, and put fibrin glue. But anyway, I assume that you had a good result with your reconstruction, so it does not cut absolutely down your possibility of reinnovation. Okay, so you can use it, but we
Using
prefer
the Surgicel. You see, should I continue using or should I stop?
You might stop using it, and perhaps if you need to wrap the nerve, maybe a vein or a muscle is better.
Because there is a case in last week. I did a posterior fossa, a large posterior fossa meningioma that was invading the internal auditory meatus, and I was dissecting. I damaged the facial nerve. Okay, and I did the reconstruction with the sural nerve and a small stitch. Okay.
Perfect.
In that time, in that hospital, in the public hospital, I didn't have the fibrin glue.
Yeah.
And the nerve was like that in the cessa, in the posterior fossa, in the CP angle. Imagine after the CSF is coming, the cerebellum come back, the brain stems come back. This small suture will be enough to keep the stump together. Because this, I was thinking to put the Surgicel and protect in some place, or there is, I don't know if I did wrong. I'm learning him, more learning.
No. What I said before, you did well, but we prefer to use other materials. You did well. I mean, the results of your surgery will be good, or the reconstruction of the nerve will be good.
But it's in the posterior fossa, and not here. It's in the posterior fossa. I cannot put muscle there.
Yeah, understood. Okay, what about the vein? You can take out the vein, for example, the jugular vein, which is a jugular vein, which is in the surgical field. You can harvest the vein.
Put the vein around the nerve.
Exactly, because what you need is some kind of reaction, of fiber reaction. Probably the Surgicel will make an inflammation, and then will resume and disappear. Otherwise, with the vein, you produce a real scar, and this avoids the nerve dehiscence with the CSF pulsation, for instance.
Oh, I never had this idea. Very interesting.
It's,
Yeah, of course.
it's cheap, very cheap.
Okay. The only thing, in the neurotube, the famous neurotube now that they want to sell for a lot of money, is to work or not? There is a
It
guy
does
here
work.
that's using neurotube for everything. Neurotube.
The problem with the neurotubes, according to the literature at this moment, at this point, is that gaps longer than 3 centimeters might fall into a dark zone. So if we have a gap longer than 3 centimeters, we prefer to use graft. If we have a graft shorter than 3 centimeters, we might use tubes. The problem with the tubes, as you mentioned, are the cost. So we don't use tubes very often. We just use grafts in our practice.
The last question to pass to Dr. Luis Felipe in Dalton. There is a difference in end to side or end to end when you use the anastomosis to the hypoglossal, and is really end to side, because the hypoglossal nerve is monofilamental nerve, no?
Yes,
You
absolutely.
cut the nerve in the middle and you use one part. Yeah?
Yes, that's end to
This
end.
end to side, the people
No,
is
not
popularized now, the end to side. Is the
No.
results are the same?
That's wrong. It's not end to side, it's end to end. Because as you saw in the video, I cut half of the nerve and then I put it here and then I put end to end. If you use
Yeah,
an
you
end to
do
side,
end to end.
yeah, if you do end to side, that's taking out the epineuron and put the nerve in the side of the nerve, okay? That's not so useful. It doesn't work so nice as the end to end.
But the people say that you have less spasms. That is very common with hypoglossal, with end to side. Because the hypoglossal nerve was too strong nerve that you give so many. It's true.
Yes. Yes, as I've shown in some of my patients, you can have some, when they take out the tongue, they can close the eye, for instance, spontaneously. But when they take out the tongue, that's completely abnormal. You don't take out your tongue in the street when you are walking. So what my point is, it's very, very well tolerated, this kind of spasm. On another side, the end to side is just maybe too weak. So the way to avoid spontaneous spasm, strong spasm, is to put the number of axons that the facial nerve has, as you saw, taking out the epineuron of both nerve and obtaining a shorter. Yeah, exactly.
Same time. Great, great. Dalton was our resident. He spent some time with you. I think he's raising his hand.
Hello, Dalton.
Quer perguntar alguma coisa?
Hello, Professor
Hey.
Sokolovsky.
Hey,
Professor
good to see
Borba.
you.
Good to see you every time. And I would like to congrats Leandro for his lecture too. Was very good, excellent. And well, my question for you, Dr. Sokolovsky, was before you mentioned that using the posterior auricular nerve as a nerve graft, but there are patients that have a lot of pain in the region innervated by this nerve that can be very morbid for some. And well, I would like to know, to ask you what is your opinion and what is your experience about that?
Well, the rate of developing a neuroma here in the posterior auricular nerve is not so high. The problem, probably, I agree with you, is the hypoesthesia of the ear. But because they are usually in the surgical field, there is less morbidity than harvesting the sural nerve in the lower limb. And besides, probably the auricular nerve, part of it can be damaged during the surgical exposure, the big surgical exposure of a skull-based tumor. So it's very well tolerated, it's sacrificed.
Okay.
Excellent.
Thank you.
Luis Felipe,
Thanks to
please.
you.
Hello, Mariano. How are you? Nice to meet you again. I have two questions in one, just two short questions. The first one, Mariana, is about we see in Brazil a trend towards mesenteric fascial anastomosis besides of hypoglossal. And I don't know if you have discussed this in the Brazilian Congress of our Brazilian colleagues, and why would be this trend? Maybe some technical issue or more difficulty or less difficulty. And the second question is, I see many colleagues here asking for neuromyography after the anastomosis to see what is the predictive value of that, and how often do you do that to say to the patient that he has a bigger or smaller chance of a good result after anastomosis?
Perfect. Thank you, Felipe, for your questions. First, regarding the first one was regarding
the mesenteric.
The mesenteric. You're completely right. And there is a trend in Brazil to use more mesenteric than in Argentina. We use more hypoglossal. You are completely right. In our practice, we have more, and as I said, more than 90% of good results. The drawbacks of our technique of the hypoglossal is that you need to drill out the mastoid bone and to take out the nerve from there. On the other side, we obtain very reliable results and predictable results. And that's why we prefer that technique. And do not forget that when you use the hypoglossal, you can reinnervate the whole facial nerve. When you use the masseter, you just reinnervate half of it, okay? And this takes me to the second question, which is how to predict the results. As I said, the results of this technique, also I have to say of the masseter, are very reliable. So we don't use any method of prediction. We just wait, and because this is published in the literature, I'm not inventing anything. The rate of success of this technique is so high that we don't need to predict a good result. We, in general, of course, shit happens, but we in general obtain good results.
Okay, thank you.
Thanks to you. Nice to see you.
Barba, teu microfone está desligado.
I see here Professor Gabriel Vargas from Colombia. Hello, Gabriel, ¿cómo estás? And Juan Luis Gomez Amador, if you want to make some question to our invite speaker, Mariano and Leandro. No? Juanito.
Yeah, Professor Borba. Good evening to everyone. Thank you very much, Professor Sokolowski. It's a great pleasure to see you. I just want to ask the role of the plastic surgeon for the reanimation of the fascial nerve. Do you think is there a place for a plastic surgeon to treat those patients, particularly those who have a long time since the fascial palsy?
Yes, the role of plastic surgeons is very important in two parts of the treatment. First of all, after the hypoglossal reanimation or masseter or whatever nerve you use, probably your results will not be perfect. In fact, I've shown the limitation of our technique. So if you need to improve your results, that's the place of a plastic surgeon. For instance, a patient that does not close the eye, you might help the eye closure with a eyelid, golden eyelid implantation. So there is a strong place. And also, if you see that the symmetry is not as good as you see, you might need to improve it with a tension suture of the hemi face, of the lower hemi face. Also, you can see that some asymmetry in the eyebrows that you can be treated, for instance, by a lifting or maybe by a section of the frontal branch. Well, those are the places in this treatment, in this modality of treatment for the plastic surgeon. And of course, we have to offer in late patients more than 2 years. As I said, 2 years is the point of closer for our technique, maybe 2 years and 2 months, 3 months as maximum, then we have to offer plastic surgery techniques, like for instance, Labet technique, rotating the temporal muscle.
Excellent.
Thank you very much.
Gabriel.
My pleasure.
Oh, just to congratulate Dr. Leandro and Dr. Mariano for this excellent review. I think that timing is something that is really important, and of course, I think that we are not doing enough cases because first of all, we wait too much and we lose the chance to recover the facial nerve. And then we don't have maybe the good anatomic knowledge of the mastoid in order to look for the facial nerve. So that is very important to train on the cadaver and to really learn where is the facial nerve and how to do it without using an ENT people. Just neurosurgeon needs to know this position, as Dr. Borba emphasized. So congratulations for both.
Thank you, Gabriel. Thank you. Let me continue my questions here. Okay. Bell's palsy. Okay. Paralysia Bell. Bell's palsy. How long do you wait to do the decompression of the facial nerve? Or if you do or not do? And how you treat?
Yeah, there is a big controversy in the literature regarding not only Bell's palsy, decompression in the mastoid bone, but also I would say after a fracture of the skull base, after temporal bone fracture that we can observe, of course, as you know, facial palsy. There is a big controversy about the utility of the decompression or the early surgery. I won't enter that. I skip that, and we can talk about the indications of this type of secondary surgery, or let's call it facial reanimation with a nerve transfer. We wait also 1 year, and it's similar to what Luis asked me at the beginning. When do you wait if you suspect that the facial nerve can appear? Then in Bell's palsy, the vast majority of persons who has a Bell's palsy, even having a Hausen-Brackmann 6, they can recover up to a Hausen-Brackmann 2, 3 after 1 year. So very, very few cases do deserve this type of technique. Same goes for fractures, skull-based fractures.
The second question was about the fracture, the traumatic injury. We saw I think 1 month ago, less than that, a lady have a severe trauma, had injury and facial palsy in the field. Okay, but has a lot of complication, clinical lung, and after 6 months, she still had a facial palsy and have a fracture that crossing over the nerve. And we decided to do the surgery and decompress. What we found in the temporal bone, in the mastoid, that there was a fracture that was just over the nerve. And you just take the bone out and the nerve was intact. See, I think it's help if you have a fracture. The problem is sometimes you don't have the fracture in the temporal bone and the patient has facial palsy. And how long you wait, this is the question. This is the question, how long we should wait. And the same situation, the Bell's palsy, you are seeing now some neurosurgeons and the plastic surgeons offering surgery after 3 months. It's crazy. And sometimes 6 months. See?
Yes.
There is I don't know what to do. This Bell palsy is a big problem today in our area here, that they want to decompress everyone. They say, oh, they decompress in one month, the patient is better. 15 days, the patient is better. It's crazy. but it's
yes.
happening around the world today. Not around the world, but in our area a lot, a lot. Okay. I don't know if
No,
I can
yes.
say something.
No, I understand your question. The thing is that with Bell's palsy, there is a big controversy about the utility of early decompression in that type of palsy. So what we do is, because spontaneous recovery of Bell palsy is occurs very often, and the patients usually do not need a nerve transfer surgery, we wait for 1 year to make a short answer to your question. So 1 year,
Great.
then we go to reanimation. It's different in some cases. If you have a fracture, a skull-based fracture that goes exactly through the nerve pathway, then decompression might be useful, and even nerve reconstruction if the compression is not possible because the nerve is already sectioned by the fracture. So in that cases, you can use a nerve graft to bring the stumps together and to reconstruct the nerves. In those cases, with a nerve fracture that you see that is crossing all over exactly the pathway of the nerve, an early surgery can of course be done.
Great. I don't know if I have more questions to Dr. Mariano. I have the last one here. Physical therapy.
Yes.
Okay. It's true that less you do, better you'll be. Less is more. Because you see today a lot of clinical kind of technique, laser, many new techniques.
Yes.
Always private, not for the public, always private. What kind of physical therapy you indicate for the patient when you do surgery?
The physical therapy, first of all, is very important. The more you do, the best your result is. That phrase that you mentioned, if you do more, you get a worse result, is referred only to a part of physical therapy or physiotherapy, only to electrostimulation. If you do early stimulation and very heavy with turning on the stimulation to many volts, then you will get synkinesis. So it's true. You do more, you get a worse result if you do very heavy electrostimulation. Otherwise, normal physiotherapy, normal training is very useful in all the patients. And regarding your question about which technique you use, it depends on the surgical technique that you use. For instance, if you repair the facial nerve with a graft, then you have to reanimate the facial nerve. If you repair with a hypoglossal, then you start moving the tongue and you will see your first movement of the face. If you use the masseter, you have to teach the patient to shut the mouth, and then they will see the first contractures of the muscle. So it depends on the technique that you use, the type of physiotherapy that you will need, your patient will need.
Excellent, excellent. And see if you have more. How long, Dr. Rolando?
Yeah, Luis Carrasco.
Please go ahead, Gabriel. Gabriel, please go ahead.
Yeah, but after the surgery, we need to insist the patient to move the tongue often. So the rehab needs to be with the movement of the tongue, or how is that?
Yes, the first movements that you see on your paralyzed face will be related to tongue movements. For instance, towards the hard palate, right? The patient moves the tongue towards the hard palate, and then the patient starts to move the paralyzed face. Once you start to have a very strong movement, then you can train independency of more movements. That this can be trained only after you have a good movement of the face. Yes, but I absolutely agree. First, you start with your donor training, and then your donor motor program training, and then you start to train the brain plasticity and to make those movements independent.
And normally, how long needs to wait until you can say, okay, the surgery was perfect or a fail?
Oh, That's another good question, because we see, for instance, after 1 year, short answer, I would say 2 years, 1 year and a half as minimum, short answer, okay? Let me explain. If you see a patient after 1 year and it's moving, maybe somehow the eye is closing the eye, but not very hard, and you put a golden eyelid here to help the movement, maybe he will recover in 2 months much more strength, and then the implant will be too heavy for that particular patient. So the point is, before doing a secondary surgery by a plastic surgeon, as you mentioned in your question before, it has to be after 2 years, and as early, I would say 1 year and a half.
Excellent. Excellent, excellent. I don't know if we have more questions to Professor Mariano. Is almost 2 hours you're here. We really enjoyed the time. Mariano, want to say something that to close the session, or?
I just want to say thanks again, Luis, for your invitation, very kind. Also for Dr. Bennett for his hard work, spreading neurosurgery all around the world, and to the rest of the people who is watching for their interest and their attention. Thank you very much. Thank you very much.
Thank you, Mariano. Thank you, all the participants. Next week, maybe next week or in 15 days, you come back with surgery of the brainstem with Professor Paulo Cadre and the special guest that you confirm in the next week. We'll be talking about surgery of the brainstem. Thank you very much. Till next week. John.
Yeah, thank you.
Thank you very much. I really appreciate it. Thank you.
As always,
Marito, nos vemos en Tarija.
Nos vemos. Thank you. Gracias.
Bueno, gracias a todos. Muchísimas gracias a todos. Chao.
Thank you very much.
Thank you, everybody. Have a good night.
Yeah. Chao.